Hello, good afternoon everyone, and thank you for joining us for today's Aboriginal Health Immunisation Update. Today's session is being facilitated by Hunter New England Central Coast Primary Health Network and being presented by Hunter New England Local Health District. So my name is Charles Broadfoot and I'm one of the Professional Development Officers with the PHN. So to open, I'd firstly like to introduce and hand over to my colleague Jessica Griffiths, who is a member of our Aboriginal Health Access team. Jess is going to do an acknowledgement of country. Thanks, Jess.
Thanks, Charles. Hi, my name's Jess. I'm part of the Aboriginal Health Access team at the Primary Health Network. I would like to take this opportunity to acknowledge the various Aboriginal countries we are meeting on today, the countries of which the boundaries are known and lived through our Aboriginal communities across the region, not by the modern borders and regions we see today, but by the natural landscapes of the land itself. I would like to acknowledge the Awabakal land I am joining you from in beautiful Mullabimba, or Newcastle as it's also known. Acknowledge the Aboriginal country you are joining us from today. Know its name, see its people. Think about what its Aboriginal culture, law and history mean to you. I would like to honour the traditional owners of these lands, our Aboriginal elders, past, present and emerging, and their ancestral tie to these lands, oceans and waterways as the first people of this country for more than 60,000 years. A sacred link to the land that the last 200 years simply cannot extinguish. I would also like to extend my respects to the Aboriginal and Torres Strait Islander people joining us today. You may walk in two worlds, but your culture, the oldest continuous living culture in the world, is a gift to this country. We always were and always will be on Aboriginal lands. Thank you.
Thanks very much, Jess. So today's session is being recorded and the recording and the slides will become available on our website from tomorrow. So you just head to thephn.com.au and click on the Education tab. We also have previous recordings there if you want to check them out. So we will be using Slido for questions today and also for the evaluation poll at the end. So you can access these on the right-hand side of your screen. Alternatively, you can head to slido.com and enter the event code AHIU, so Aboriginal Health Immunisation Update. And a third option is by scanning the QR code that has popped up on your screen. That'll also take you to these tabs. So please type your questions in throughout the session today. We do have members of the immunisation team who will be able to type responses, but we will also have a panel discussion after the main presentations. So it's now my pleasure to introduce today's speakers. So we have Patrick Cashman, who is the Immunisation Coordinator for Hunter New England Local Health District Public Health Unit. We're also joined by Paula Taylor, who's an Aboriginal health worker in the immunisation team for Hunter New England Health, and also Jodie Stevenson, who is a clinical nurse consultant in immunisation in the same team. We're also joined in the room by Sharon Saxby, who is a clinical nurse consultant, and she'll be in the background answering your questions as well. So without further ado, I'd like to hand over to Paula to start us off.
Thank you. Thank you. Hi, my name's Paula Taylor. I'm a proud Aboriginal woman from Wellington, New South Wales, Wiradjuri country. I too would like to acknowledge that, that we are meeting on Aboriginal land today and that we all live and work on Aboriginal land, and pay my respects to elders past, present and emerging. So I work with Nat Allen, who's also an Aboriginal health worker based in Tamworth. Together we run the Aboriginal pre-calling program. The program is designed, we contact parents before their babies are due for immunisation, and we also contact them, we send text messages before each immunisation milestone is due. We're phoning parents just to make sure that they're aware that bubs immunisations are coming up. They know where to get help to get bubs immunised. They know about the resources available to them. So we email our parents the links to apps to make sure that they're aware of all of the possible resources that we have available to them. A lot of the families also have immunisations that have been done but aren't really being recorded correctly on their immunisation register. So we contact the services provider on their behalf and fix those up as well. We also let families know about Meningococcal B vaccine currently, and making sure that they're aware of the Panadol requirements and that they're aware of why that vaccine is important for their babies. So if your families have received a text message or a phone call or a letter from the Immunisation team Aboriginal health workers, it's possible that it's from Natalie and I. And if you have any families that you'd like us to assist or services, please reach out to us. Thank you, and I'd like to hand over now to Jodie.
Hello. Thank you so much for joining with us today, and thank you, Paula. So Paula's contact number, 49246 664. That's 49246 664. Okay, so my name's Jodie Stevenson. I just wanted to give a quick overview of what we know so far about influenza 2021. I know, we were so surprised as well. We're all set on COVID, but there's a flu season this year as well. And I just wanted to touch on cold chain requirements, just to make sure that we're all set and sorted, ready for both influenza and COVID vaccines. So delivery date still to be confirmed, but the Ministry of Health is asking that you don't book any vaccination clinics until that vaccine's in your fridge. So sometimes we like to book ahead and book in extra staff or extra rooms. Ministry's saying hold off, wait till it's in your fridge and then start your planning. This year it's on a pre-allocation system based on what you ordered last year and what was left in your fridge. So jump online and see what's been allocated for you. Then have a look in your fridge. If you don't have room for that much vaccine, reduce your order. And keep in mind, at some point you're going to get COVID vaccine as well. So it might be time to think of that second fridge. And don't waste your time on a little fridge. If you're going to get a second fridge, make it a useful size. The other thing the ministry is asking is, they've sent a survey out 3 times about use of flu vaccines and what's left in your fridge. And they're suggesting to avoid delaying your vaccines, please complete the survey. It's 4 questions and one of them's your name. So please have a look at that for your service. If you don't have it, call the vaccine centre and ask for the survey. And the new thing, which we're doing with other vaccines, is you have to acknowledge receipt of your vaccine before they'll send you the next lot of vaccines that you've ordered. So when your vaccines arrive at your service, jump back on the New South Wales online website, and there's a button under order vaccines that says receipt of vaccines. Really, really important. So all vaccine orders must be online now. Please keep all your vaccines in their original packaging. They're not designed to be exposed to light, so keep them in their boxes. So again, make sure you've got enough room in your fridge for all your flu boxes. The ministry is suggesting that you order 4 weeks worth. It's not to say you won't get more within 4 weeks, but if you can, order 4 weeks worth at a time, and make sure that your service has access to air, that your staff have PROTA numbers, and you as the GP in charge there can allocate air access to your services, because all influenza vaccines need to be recorded on air, but it's mandatory for all COVID vaccines to be recorded on air. And you're wondering, who am I giving flu vaccine to this year? Same, all Aboriginal and Torres Strait Islander people from 6 months and over, not 5 months and 3 weeks, 6 months of age and over. And same recommendation, children less than 9 have 2 doses in their first year, and then 1 dose every after. If your little possum arrives after having 1 dose last year, they then only get 1 dose this year. So it's just 2 doses in that first year. So that's all I can tell you about influenza at this point, but there'll be lots more coming. Just a quick heads up on cold chain. This is your take-home list of things to do for your fridge. Ensure you have a min-max battery-operated thermometer, so not just the one built into the top of your fridge, but a separate battery-operated one with its little probe inside an empty vaccine box, and that battery needs to be changed every 6 to 12 months. So now's the perfect time, so you're good to go. Your fridge needs to be serviced every 12 months. Now's the perfect time to book that in before your flu and COVID vaccines arrive. Ensure that your data log is set for every 5 minutes. Not 3, not 7, needs to be 5 minutes as per Strive for 5. No vaccines are to be stored on your floor of your fridge. I know it looks like good space, but it needs a shelf there so air can get up and under around it. a cake rack, so the little trays that you take out of the oven, if you don't have a shelf, they're perfect. Ensure you and at least 1 or 2 other staff members in your service know how to download your data logger. So when there is a cold chain breach, you'll be able to send it to us. Complete your annual Strive for 5 self-audit and consider purchasing that extra purpose-built vaccine fridge now if you think you'll need additional storage. No bar fridges, no domestic fridges. It needs to be a purpose-built vaccine fridge. And as Patrick Cashman said, the best fridge is the one you can get access to at the moment. Thank you so much. Any questions? Please don't hesitate to call us 49246477, 49246477. Thanks, team.
Thanks, Jodie. That's terrific. I'd like to thank Jess for a wonderful welcome. That was just fantastic. And welcome to country. And thank Paula for speaking today. And we'll talk about immunisation, and specifically we'll talk about immunisations for the COVID pandemic. But this is not the first pandemic for UMOB. I mean, up until 1788, health of Aboriginal people was really good. People had really good nutrition, living on their own country with their own families. And then 1788, the ships came from England and smallpox came to what we now call Sydney Harbour, and the Gadigal people got decimated by smallpox. It's estimated that between 50 and 70%, so over half of the local Aboriginal people around there died of smallpox within the first 2 years. So this COVID idea is not new to Aboriginal people, unfortunately. Now, if you had to close the borders then, that might have been a good idea. But anyway, that didn't happen at the time. So, but the point is that smallpox is completely controlled now with an immunisation. There's a vaccine for smallpox, and everyone in the world nearly got that vaccine, and now we don't have smallpox anymore. It doesn't exist. Now, smallpox is an interesting disease because, as well as killing people, it's a terrible disease. It used to give people these pox, what we call pox, which would really discolour their faces and give them, made people quite ugly. So we probably imagine this beautiful Aboriginal people there in 1788 and all these poxy people getting off the boat. But unfortunately the smallpox spread. But stopped with a vaccine. So vaccines is a really important part of Aboriginal health. And you providing vaccines for your community is going to be so important to keep everyone healthy. And so that you guys can continue to look after this country. Always was, always will be Aboriginal land. And hopefully you can see some of your country there in Kamilaroi and Warramai and Biripi and Awabakal country and Anawan country further up north. So this is the immunisation schedule, and this is what we use to keep Aboriginal children mainly healthy and adolescents and older people. And the COVID vaccine's not on there, but the COVID vaccine is free and funded, and it'll be coming to your AMS soon. So it's all a bit new. But first we'll talk about some of the vaccines that changed last year, just to keep you up to date. So the pneumococcal vaccines, the schedule changed last year and became a bit simpler. So why are we giving pneumococcal vaccines for Aboriginal people? You can see the solid lines there are different age groups of Aboriginal people, and the broken lines are non-Aboriginal people, and you can see the rates are much higher, 3 times higher in children under 5, 10 times higher in people between 5 and 49 years of age. So being able to give pneumococcal vaccine to Aboriginal people is really, really important and life-saving. So you would have seen uncle or aunt die of pneumonia at some stage, and this vaccine really prevents that condition and makes a huge difference. Now when it started, so pneumococcus is a terrible bacteria, lives in people, but it also, as well as getting into the bloodstream and killing people, getting into the lungs and causing pneumonia, also gets into the ears. Now when these vaccines became available about 15 years ago or so, Aboriginal kids living in urban and regional New South Wales, their ear health improved out of sight. So this is a really important vaccine for children on the schedule. So this is the changes that happened last year. So on the far left-hand side is the schedule for Aboriginal kids in New South Wales. And that's the same schedule as non-Aboriginal kids. And that's great news. That's really good news because it means that the infection rate in Aboriginal kids in New South Wales is no greater than non-Aboriginal kids. So the schedules are the same. So that's at 2 months and 4 months, can be given as early as 6 weeks, and then again at 12 months of age. But if you're moving around, working in different communities in WA, Northern Territory and Queensland, Aboriginal kids get an extra vaccine at 6 months, and then also pneumococcal vaccine. That's that second column there for kids living in remote communities. Now the third column, the middle column, is a really important column. So that is for everyone over 12 months of age who has a chronic condition where they're more susceptible to pneumococcal disease. So that kicks off with a Prevnar and then 2 pneumovaxes afterwards. And now that we used to give regular pneumovax, so pneumovax 23, that's the one with 23 serotypes in that vaccine, polysaccharide vaccine. We used to give multiple doses through the lifetime, but now it's just 2 doses only over a lifetime. So if you've got a young person, they've already had 2 doses of the pneumovax 23, we stop that. We just give a Prevnar, the 13-valent Prevnar conjugate vaccine, and we don't give any more 23. Now the fourth column there is really important. So that's for Aboriginal people that don't have a condition where you're going to start the vaccine earlier. At 50 years of age, we give 1 Prevnar and then wait 2 to 12 months, preferably 12 months, and then give 2 pneumococcal vaccines 5 years apart. So that's what we're doing in AMSs now. So the main columns there for you is the first column for Aboriginal kids, the middle column for Aboriginal people over 12 months of age who've got a chronic condition or susceptible to pneumococcal infection, and then the fourth column there for all Aboriginal people who've turned 50. So if you've got Aboriginal people that you're looking after at your AMS and they've had 2 pneumovaxes, then recall them and give them a Prevnar. Now the Prevnar covers less serotypes, that's why it's 13, not 23, but it works much better and will really cut down disease. And this is really, there's great examples where when we vaccinate part of the community, we make the other part of the community healthy because those bacteria are not spreading through the community as much. So this is a really important vaccine, free and funded. Now the risk conditions, how do you know if someone's over 12 months but less than 50 and has one of those risk conditions? And there they are. So some of them are quite specific, like CSF leak, but some of them are very general. So chronic liver disease, chronic kidney disease, and respiratory illness for people over 12 months of age. That's really important because it causes pneumonia, and also just some general things like smoking or heavy alcohol use. So that's pneumococcus. Now another nasty bacteria is Meningococcal B, and this vaccine is free and funded for Aboriginal children all over Australia less than 2 years of age. And I'd be very surprised if some of you don't know Aboriginal children that have had this terrible disease and now have permanent disability, or even worse, they've passed away from this terrible disease. So we really want to keep kids alive, and this vaccine's free and funded and will really make a big difference for Aboriginal kids. So it's on the routine schedule for all Aboriginal children in Australia at 6 weeks of age, 4 months of age and 12 months of age. So it's 3 doses. Now there's funded catch-up for under 2-year-olds, for Aboriginal kids under 2 years of age until June 2023. So it's really important that we catch kids up because that's going to be a limited catch-up. So we won't be able to catch up kids forever. So you really want to make sure that you're recalling all Aboriginal kids under 2 and giving them this vaccine. So if they're following the schedule, it's 6 weeks, 4 months and 12 months. If they start this vaccine over 12 months of age, it's just 2 doses 2 months apart. If they start this vaccine under 12 months of age, it's always 3 doses. Yep, always 3 doses if they commence under 12 months. So if they come in and they have one at 6 weeks, but then they miss some vaccines and they don't come in for their second one until they're over 12 months of age, they still get 2 more because they commenced under 12 months. We want to give them 3 doses. Now this is not included on the no jab, no pay calculation. So so it's not prompted that way, but it's really prompted by your knowledge of your community and recalling people and bringing them back and giving them this vaccine. We've seen many, many times in Aboriginal childcare, Aboriginal kindergartens, this terrible bacteria get in there and cause disease and disability and sadness, and we really don't want that anymore. And this is preventable now, funded for Aboriginal kids, so please bring them back in. You can see here the increased risk. So the blue bars here are for Aboriginal people. Across the x-axis, across the foot of this table, is in age groups. And on the far left are little kids. And you can see there that little Aboriginal kids in blue get meningococcal B disease much, much more than non-Aboriginal kids in red. So this is really important. This is a life-saving vaccine and a terrible, terrible illness. And I'm sure you've got stories of people you know who've had this. So we really can prevent it. The vaccine's free and funded, but it's up to you to bring people in and talk to mothers and fathers about this. Now, if we look at, you know that there's meningococcal B is not the only disease. There's C, A, and other serotypes, Y. But you can see the B is causing most of the illness in Aboriginal children. So that blue line across the top is meningococcal B. So this is really causing a lot of the illness, and we really want to give that to Aboriginal kids. Now, if you're working with Aboriginal kids who've got other chronic illnesses, they get an extra dose at 6 months of age. Now, they're quite specific illnesses, and that is if you treatment with Acknowledgement, if the child doesn't have a spleen, or if they've got complement disorder. Now, Charles told you about filling out the Slido and the feedback, so we don't want you to have a complement disorder when you're doing that. But if you've got a child with a complement disorder, please give them an extra dose of Bexsero. Now, the prophylactic Panadol is really, really important. Now, in the UK, they've been giving Bexsero to all children in the United Kingdom for over 5 years. So this is a really safe vaccine used for the whole community in the United Kingdom. In Australia, it's only funded for Aboriginal children under 2. So in the United Kingdom, they've got a lot of experience of giving this vaccine to kids. And you give a dose of Panadol, then give the vaccine, and then 2 doses of Panadol afterwards. This is a study from the Journal of Pediatric Infectious Diseases, a recent study published last year. And they looked at kids who had the Panadol and kids who didn't. And some of the kids that didn't have the Panadol got high fevers and then ended up having septic screens, which is blood taken to see if they've got an infection, because they've bounced back into the emergency department, the local ED afterwards, with a fever because they've had this vaccine. And if you give this vaccine and the regular vaccines on the same day, the chances of fever are higher. But what they found in this study is if the child has paracetamol, not Nurofen, but paracetamol, that fever is really controlled, and then there's no confusion thinking the child has another infection. So it's really, really important to do. But by the same token, don't send families away. If they bring their child for this vaccine, don't send them away because they haven't had paracetamol beforehand. That's really poor healthcare. We want to really make sure that if the parents have bought, or the auntie or anyone brings that child for Bexsero, really important they leave having had that vaccine. So don't turn them away because they haven't had the paracetamol. You can give them some paracetamol and you don't have to wait. Just give the child the vaccine, the Bexsero, and then make sure that they've got access to paracetamol for 2 more doses that evening, 6 hours apart, and that will control the fever. So the message is paracetamol is important. Make sure the kids have it, but don't send the child away if they haven't had paracetamol. Make sure family's got access to paracetamol and that they know how to use it, and that will control the fever and make that evening much more comfortable for that child and that family, so they don't bounce into ED and get worked up unnecessarily. The Bexsero is also funded for other conditions, very specific conditions, someone without a spleen, complement deficiency, and Acknowledgement treatment for all ages. So it's funded for not only children. Now, in the Immunisation Handbook, we find it hard to find our way around now. It's online. It was much easier for old people like me to thumb through a book. But there's some really, really good infographics in the handbook, and I suggest you have a look, flick through those, find out what's of interest to you and your colleagues, and get them up on the wall of your AMS. So let's talk about COVID vaccine now. So COVID, Australia's done very, very well keeping COVID out. But look at what we've had to do. We've had to close the airports, close the ports, cut down so many things. And Australia's done very well as a group, and specifically Aboriginal communities have done very well keeping COVID out of Aboriginal communities. And we can only imagine that if COVID got into those communities, we've seen what's happened in the United Kingdom, in the United States, Indonesia, just north of us, decimated with COVID, India, places all over the world where that virus has got into communities. So we just don't want that picture. So this vaccine, like eradicating smallpox in the past, we want to give this vaccine to communities because at the moment we're stopping a lot of communication with communities and people coming and going. But that's not a strategy that's going to last forever. We can't block out the world forever. We need to prepare all the bodies of all the people in the communities to build up antibodies to protect themselves, and so that if that virus comes to that community, people are prepared by having the vaccine and people are not going to get sick, or not as sick, and not as many people sick. So it's a really important strategy. So we want to vaccinate now. We've got a window before this virus comes into Australia to vaccinate the most vulnerable people, and that includes Aboriginal people, especially Aboriginal elders. But understandably, and there's a great quote here from Annie B. She's from Top End, she's a Larapinta person from Darwin, and she's saying, well, we really need to talk to Aboriginal people. It's one thing for the scientists to have a vaccine in the laboratory, it's another thing for doctors and nurses and health workers to have it at the clinic and ready to give. But if the community are worried about that vaccine or nervous about having it and they're not going to roll their sleeves up and have it, then all that's no good. So it's really, this is where the cultural importance of working in an AMS is so important. What's the difference between an AMS and the average GP down the road? Having Aboriginal healthcare workers there is the key. And knowing the community and being culturally acceptable and culturally understanding, so that people will come to the AMS and feel comfortable. There's got to be that difference there, that they feel comfortable. Hopefully they feel comfortable going to any GP, but they should be feeling more comfortable at the AMS. And if this vaccine's new, Aboriginal people are going to be nervous having it, so you need really good healthcare and to look after Aboriginal people so they feel confident having that vaccine at your AMS. And this is going to be really important, and again, a life-saving vaccine. And hopefully we can open up again and we won't see Aboriginal people decimated from COVID. This is a lovely quote here from Annie B. She says it's so new, and I guess they need more time to be reassured that it's safe and of the benefit. So talking and yarning about the vaccine with the community is really, really important. Now, she's willing to have it, but she says one of the issues for generations of Aboriginal people is being forced to do things they haven't clearly understood what is happening and the consequences of the action taken. So you can't just grab a bus, run around the community, load everyone up and jab someone. You've got to communicate slowly and carefully and listen. People will have questions, and that's why an AMS is so important, because you've got that time to take to protect the community. It's not just about quickly running out and jabbing as many people as possible. It's doing it in a way that the community will accept and understand the vaccine and what it's for. Now, Aboriginal healthcare workers in many parts of Australia, in the Territory, Queensland and WA, can give vaccines, but not in New South Wales. So Aboriginal healthcare workers have got that really important role of cultural brokers to work with community, to understand their fears and worries and find answers, whether it's talking to the doctors in your practice or the nurses in your practice, or reading up or finding out from your public health unit, what are the concerns of your community, how can you overcome them, and make the community comfortable to be having this vaccine to protect them. Now, at the moment it's really difficult because thankfully we don't have COVID very much in Australia at all. So people don't see the need. They don't see people dying of COVID. They don't see people in ICU from COVID disease. So that whole conversation about why it's important, it seems a little bit theoretical, but we know the borders one day will open up. That virus will come to Australia. We need to be prepared for that day. And the only way we can prepare for that day is having a vaccine and having as many people who had the vaccine as possible, especially in Aboriginal communities. If only a few Aboriginal people have the vaccine, then when that virus comes one day, it's going to spread through the community really easily. If nearly everybody in the community's had the vaccine, that virus can't find its way in, it won't circulate, and the whole community will be safe by protecting each other. This is really a community vaccine. Vaccination's a community activity. where we all do it, we look after each other, have the vaccine, work with people so people are comfortable to have it, have their questions answered, don't rush, and make it a good experience, and let's protect people for the future so that at the moment we don't have any COVID in Aboriginal communities, and even when the borders open up, that's the way we want to keep it. Now there's special training from the Commonwealth Government. There's a link here. You can just search health professional training for COVID. So all doctors, all nurses, everyone, pharmacists, everyone giving the vaccine's got to do the training. And there's also some modules there for practice managers, Aboriginal health workers, who can do those modules as well and get a certificate so you know, so that you're able to answer some of those questions from community. You won't be able to answer everything here, but it will really help. And then hopefully you've got to make sure that when you want to offer a culturally understanding and appropriate service where people feel comfortable, but it's also got to be medically accurate. You've got to give the community confidence that you know what you're doing. The vaccines have been stored at the right temperature, and Jodie's talked about the importance of the cold chain, that you're giving the right dose. You see the hullabaloo in the newspapers last week with a doctor in Queensland giving the wrong dose in an aged care facility. That doesn't help confidence. So as well as being culturally appropriate, you've got to also be medically accurate so that people are confident that at your AMS, when they go there, they're going to get the right dose in the right place, given the right way, all those things. And so the training's really, really important. So if you like the training, let me know because I contributed it. And if you don't like it, please let Greg Hunt know. So who's going to have the vaccine? So the vaccine's coming in little bits and pieces from overseas. So we don't have enough to vaccinate 25 million people today in Australia. And also, so there's a priority of who we vaccinate. And I know Christy Crooks and Peter Massey have done a lot of work in working out who should have the first vaccines and how do we work that out. And in Australia at the moment, obviously you've seen lots of stories on the news about the virus coming in through the quarantine hotels. So the first people to get the vaccine are people working in the quarantine hotels. So that top one is phase 1A at the top. Frontline healthcare workers, so that's doctors, nurses and Aboriginal healthcare workers working in A&E, and aged care facilities. We've seen that this virus sadly really decimates older people. So they're the first people in Australia to get the vaccine. Now phase 1B, so this is where you guys come in, Indigenous people aged 55 and over. So this vaccine will be distributed to AMSs, and Indigenous people 55 and over will be the next phase of people. And this seems to be a nice fit. So Aboriginal people are used to being treated not the best at times by the health service. So sometimes I know Aboriginal people have felt like guinea pigs in the past, where the vaccine's gone to Aboriginal communities first, and they say, well, why us first? Why isn't anyone else having this? What's going on? But this is a nice order here where Aboriginal people are not first, they're not guinea pigs, but they're certainly at the top of the queue. So there's no need to be nervous about having some sort of new vaccine because it's not a guinea pig situation for Aboriginal people. Phase 1A having first, and then phase 1B. And we know this vaccine's been used safely and well overseas in many, many countries. We see that in the news. So part of phase 1B also is non-Indigenous people over 70, other healthcare workers, younger adults with underlying medical conditions and disabilities. So that's a very similar group of people as what we talked about with the pneumococcal vaccine. So Aboriginal people under 55, but if they've got other conditions like diabetes, heart disease, then you might be looking at offering that vaccine if they want it in phase 1B. And then phase 2A, 2B and phase 3 will roll through the rest of the community. Now in phase 2A, Indigenous people aged between 18 and 54. So this vaccine isn't given to anyone under 18, Indigenous or non-Indigenous. It's a vaccine only at the moment, it's only licensed for adults. And you know the story of COVID, that it mainly affects older people and adults, and thankfully children are fairly spared. There'll be more testing and things on the vaccine of children later on, and maybe in the future children have the vaccine, but this first rollout in Australia this year, we're not offering this vaccine to anyone under 18. And there it is, that's what you're going to get come to your AMS very soon. So we think pretty much that it'll be the AstraZeneca vaccine used in Aboriginal communities and used in all general practices in Australia. So this is the vaccine that will keep in your normal vaccine fridge between 2 and 8 degrees. So you don't need a deep freezer. This stores under normal conditions. So all that wonderful practice you've had for years about charting the temperatures, downloading your logger, watching what's going on, doing something if it's out of range, sending Jody your vaccine audit, fridge audit, that all comes in now, so that this very, very precious vaccine you're able to store and look after your community by having it at your AMS. So this is the vaccine that's used in the UK. This is the only vaccine being used in the UK. So all the older people in aged care facilities, all the healthcare workers, all the frontline people, everyone in the UK is having this vaccine. Now it comes in a multi-dose vial. So that poses some challenges, and that's where working really well and knowing your product is really, really important. So one of the challenges of a multi-dose vial is infection control. So all the vaccines we use, apart from the COVID vaccines, are single use. It comes in a syringe, you give it to someone, and then you put it in the sharps container. Or it comes in a little vial like MMR, you mix it up, you give it to the patient, and then you dispose of it. This is a multi-dose vial. Obviously, billions of doses have got to be distributed around the world. The packaging for a single use, the expense of that is way too much, so it comes in a multi-dose vial. Now the AstraZeneca vaccine, you can see that there's 3 different types. Now you would have seen on the news, was it yesterday? The first AstraZeneca vaccines come to Australia. So that's that second line there, imported stock type 1. And you can see that in the multi-dose vial on the far right, 10 doses per vial. So that's what's come. Now CSL, the Australian company, Commonwealth Serum Laboratories, are going to manufacture this vaccine. They've been given the recipe by Oxford AstraZeneca, and they're going to manufacture this vaccine in Broadmeadow. That's Broadmeadow, Melbourne, not Broadmeadow, Newcastle. So they're going to manufacture that. So that top one there, that's what they mean by the local CSL. But this first lot of vaccine that's arrived by plane is obviously the imported stock. Now later on, there'll be a different vial imported, and that will only contain 8 doses per vial. And you'll know that will be marked whether you've got a 10 dose or an 8 dose vial. But look at the second column there, dose volume, 0.5 mils for the local CSL one, 0.5 mils for the imported type 1, 0.5 mils for the imported type 2. So the dose of the AstraZeneca vaccine for everyone that you give it to, everyone over 18, is half a mil. It's half a mil. Now, as far as I know, regular general practices have to provide their own needles and syringes. I've been asking here at the PHN about what's happening with AMSs, and I don't know. I know my friends at TAMS have emailed me and asked me. I don't know. So I don't know whether AMSs will be supplied needles and syringes from the Commonwealth, but I haven't seen that anywhere. As far as I know, you'll probably need to be supplying your own needles and syringes. So for half a mil, that would be your regular 2 mil syringe. And there it is again. So it's a multi-dose vial, but you don't mix between vials. So if there's a little bit in the bottom of the vial and you think, oh, this is very precious, I want to use it, you don't suck it up and then start with the next vial. If you haven't got a full dose, you dispose of that and then start the new vial fresh. So you don't mix them up. There's been lots of work done on the thermostability of this, and I'll show you that in a minute. But once it's in the syringe, we don't store it and keep it. Once it's drawn up in that syringe. So you wouldn't want to draw up a whole lot of syringes from a multi-dose vial in the morning and then have your 10 syringes in a kidney dish and then use them over the day. That's not recommended. So you draw it up as you use it. It's not recommended to leave it sitting in the syringe. But it will sit on the shelf. So the multi-dose vial, you could have that on the bench at the clinic for up to 6 hours. I suggest you don't go anywhere near 6 hours, but it could be there for up to 6 hours. And then once it's open, it can be in the refrigerator, in the vaccine refrigerator, for up to 2 days. So your stock control is going to be really, really important. So if you're running a big clinic and lots of people are lined up outside the door, you can draw stuff up and be giving it to people. It's sort of like a mass vaccination situation. But if people are coming in and as they're having their their diabetes checked, and as they're seeing the doctor or the healthcare worker, and you're giving it as you go, then the stock control is going to be really, really important. How long has that vial been open in the fridge? How long has that vial been sitting on the bench? How long has that syringe been drawn up? So you're going to need little labels, and you're going to need really good stock control so that everyone knows what's going on. Now the vaccine itself, how does it work? So it's an adenovirus depicted here, and you can see there the little red thing on the inside is the DNA of the coronavirus, the COVID virus. So the other vaccines that we see are messenger RNA vaccines, whereas this is the genetic information is coded onto the DNA. Now the adenovirus, you can see it up there, that's that hexagonal thing with the little things on it. Now the adenovirus is a virus that we have, that we catch every year. It causes the common cold, but it's quite hardy. And you can see the DNA, the code, the little spirally thing in red on the inside is put inside the adenovirus. That adenovirus goes into the human cell. So that blue thing on the big blue round thing is the human cell. That then goes inside, the adenovirus disgorges that DNA into the human cell nucleus, and that codes the nucleus to make messenger RNA. You can see that popping out of the nucleus there is a little squiggly thing. That then tells the nucleus, let's make these spike proteins, and the spike proteins get expressed on the external part of the human cell, and then those blue Y things are the antibodies. They come and recognise that spike protein, then they make lots of antibodies. So if you ever encounter that real COVID virus in your respiratory tract in the future, those antibodies know about it and are able to disable it. And it also builds what we call cellular immunity, so T cells as well. So you've got your antibodies built up after you have the vaccine, and that's how it works. You can see there that because the code is put into this adenovirus, it's really, really hardy, and that's why you can store it in a normal fridge between 2 and 8 degrees. It doesn't need to be deep frozen like the messenger RNA vaccines, and it's also why it can sit on the bench for a few hours. It's really, really hardy. But it works really, really well and then builds up antibodies. Now the original trials, the vaccine was just given a few weeks apart, but they found if they give it 3 months apart, so a 12-week interval, it works much, much better. And people are worried about, for some variants of COVID, that this vaccine's not going to work as well. But with the increased length of time, it seems to be working very well for most types of COVID. So the efficacy, so this is from the Lancet paper from December. So in the trials, 10 people got sick, 2 of which became quite sick, and they were all in the placebo group. So that's the group that didn't have the real vaccine. And the vaccine efficacy, looking at it after 14 days, was 70%. The number that's often quoted is 62% from the trials, but with that increased length from a few weeks to the 3 months, the efficacy comes up. Now, when you give this vaccine, some people are not going to feel too good the next day. And it's the regular things there, that it's the sort of stuff that you see when you give vaccines to anybody. So headache, fatigue, myalgia, which is muscle pain, malaise, which is feeling tired, fever and chills. Over 30% of people felt they had a fever. Some people get GIT symptoms, so nausea. So these can be managed really, really easily and well with good information. So if the arm's sore, put a cold compress on it. So I know from talking to people in the UK that have had this vaccine, that evening and the next day they felt pretty terrible, but afterwards they felt fine. So you might get people come back to your AMS the next day just feeling lousy, and they had the vaccine the day before, then that's sort of normal-ish. Now you'll see that effect more in younger people. Younger people have a stronger immune system, so when you give that vaccine to a younger person, their immune system's going to react, and you'll see some more of these sort of symptoms. In older people, their immune system is not quite as good, and you won't see these symptoms quite as much. But good care for people afterwards, so it's probably not necessary that they go to the emergency department. They come back and see you. You can treat them symptomatically. Now you can see there that if people get knocked around by the vaccine, you probably don't want to give all the staff in the AMS the vaccine the day it turns up, because you might not have many people at work the next day. So you need to manage that as well. But simple, sensible remedies like the cold compress, taking paracetamol, having rest are important. Of course, normal germs and bugs are circulating in the community, so you don't want to miss another infection because you assume someone's got a side effect of the COVID vaccine, so you still need to check people out if they've got ongoing illness. Now, this vaccine is being distributed by the Commonwealth Government. All the information's come from the Commonwealth Government. Now, under normal situation, all those vaccines you've got for kids and adolescents and elders in your fridge at the moment all come through the state government, all come through New South Wales Health. This is completely different. This is the Commonwealth Government. So the way things are done are slightly different. Now, when you get this vaccine, there'll be an online portal that you can access, and then when you report, you've got to report on this online portal that you've received the vaccine, and you've got to report every day what's happened to the stock. And if you have any wastage of more than 5 vials, you've got to report online to them. So if someone has a side effect of the vaccine, you contact us at the Public Health Unit and we help you through that. If you think it needs to be reported to the TGA, you then let us know about that. But in terms of the stock management, that's all done through this portal to the Commonwealth, and there's a telephone number there that the Commonwealth will have staff there to help you. So stock control, it's the Commonwealth; adverse events, the local Public Health Unit. Now, it's really important, it's actually mandatory, so it's law now. It went through the Commonwealth Parliament about 6 weeks ago, that you must report every vaccine given to the Australian Immunisation Register. And when people come for their second dose of COVID vaccine, you need to check when they had their first dose. Now, most AMSs in our area use medical software that automatically reports to the AIR. But there's been lots and lots of changes to the AIR, and if your software is a little bit out of date, your practice manager's trying to save some money by not updating it very regularly, that's going to cause a problem. So make sure you've got the latest update of best practice or medical director or Communicare, whatever you're using. I think most people in our area use Communicare, most AMSs use Communicare. Make sure you've got the most up-to-date version. It's not the place to save any money now because the mandatory reporting to the AIR. There's been a lot of work on vaccine safety, so you can really reassure the community members that vaccine safety is taken really seriously. We do a lot of monitoring of vaccine safety, and we've been part of setting up the AusVac Safety vaccine safety monitoring, and which reports to the TGA once a week, so that if there's any problem with the vaccine, it will be found. So you really can reassure community members that although this vaccine, we haven't had it very long, it's what we call a phase 4 trial. So the phase 1, phase 2, phase 3 are done before it's licensed by the TGA. The TGA then licensed the vaccine in Australia, and these phase 4 studies that we've helped design are monitoring vaccine safety. So if someone looks at you as you're about to give the vaccine into their arm and they go, is this really safe? Is anyone watching? You can really reassure them that there's lots and lots of work being done on vaccine safety. And if you're interested in looking more of that, if you look at AusVac Safety, which is the umbrella group that organises this, and they've got lots and lots of different means of doing it, and the Vax Tracker program is something we've been involved in. But the adverse events, if there are any adverse events, then you report them to us in the Public Health Unit. So this is from the New South Wales Health website. So that decision tree there, if you on the left-hand side are for minor adverse events, and you just look after them and there's no need to report them. On the right-hand side are more serious ones, and then you report them using the form on the right, the National APHE reporting form, and you report them to the PHU. So adverse events to the PHU, that's us. And Jodie's leading a lot of national work on adverse event stuff at the moment, and Professor David Durheim, who leads our unit, is on the New South Wales expert group on looking at adverse events. So these are all looked at very carefully. So adverse event reporting to the PHU, but cold chain questions and reporting and regular reporting back on the COVID vaccine only goes to the Commonwealth. And I'm going to stop there, and hopefully we've got time for questions, and we'll take some questions. But the main thing to remember is that people need reassurance, and that AMSs have an extra responsibility that most general practices don't have, to be running a culturally appropriate practice with Aboriginal staff, providing specific and informed reassurance and information to the community, so that we get these rates up and keep COVID out of Aboriginal communities in our area. And Paula and Jody are going to join me. And Todd, the magic man from behind the scenes there, is going to bring them into picture. How are we doing this? You got questions, Jody? Or?
Yes, I do, Patrick. Yes? We've had some questions. So, one of the questions, I'm sorry, I didn't write down your name. We've gone old school with pen and paper at the front here. What are the interactions or adverse events like in people with chronic conditions having the COVID vaccine?
Yeah, that's a great question. So, in general terms, someone whose immune system is not quite as good because they've got diabetes or they've got heart disease or they've got another chronic condition, they're not going to respond to the vaccine quite as well, which is why that push to get it to all the community is so important. So the adverse events is probably going to be less in someone like that than a young fit person that's maybe 20 years old and plays football, has got a really strong immune system. They might be knocked off their feet the day after the vaccine, whereas the person with a chronic condition is more likely to be okay. This vaccine seems to be very, very safe, and there haven't been description of serious adverse events described in the trials.
Excellent. And can I give Bexzero with other vaccines, or am I better off separating it, given what we spoke of with fever?
I think we'll throw that one to you, Jody.
Okay. So the recommendation in the Australian Immunisation Handbook is to give all due vaccines at a visit. And if paracetamol is given, the fever should be really not an issue. So your recommendation as a healthcare worker is to give all due vaccines. Mum, on the other hand, may decide to separate them. The thing you need to keep in mind though is influenza vaccines coming up and COVID vaccines are coming. You may struggle to find time to bring mum back the next week or the week after. And busy mums and dads and aunties may think that the task is done when they've been for that visit. So it can become complex on catching Bubby up. So yes, you can safely give them all at the one visit. If mum has not had paracetamol beforehand, you can give that dose at your surgery. If Bub has not had paracetamol, you can give that at your surgery, and just make sure that there's 2 further doses at home that evening. Okay, so the little child is now 2 years of age, or just over 2, and they started the Bexzero when they were 18 months. Can I still finish them off with a funded dose of Bexzero?
Absolutely. Yes, we really want to make sure all those kids are protected, so we don't stop. So even if they're just prior to their 2nd birthday, please give them a dose and then complete that course after the 2nd birthday.
And Patrick, I don't think we spoke about what's the gap between COVID vaccine and either influenza or pneumococcal or meningococcal, any other vaccine that we're going to give to our over 18-year-olds? Can we give them on the same day as our COVID vaccine?
No, with COVID vaccine we don't. That's a great question, and surprising as it may be, there may be some unanswered questions from this presentation, so do keep in touch with us to find more stuff out. But yes, ATAGI, which is the peak advisory group on immunisation in Australia, is advising at least a 2-week interval between the influenza vaccine and the COVID vaccine. So Jody spoke about the influenza vaccines earlier. So it's really important that you respond to that survey so that you can order those vaccines. We don't know the specifics about the brand names and things yet, but we do know that you're not going to bring people in and be giving COVID vaccine and influenza vaccine at the same time.
And if I do inadvertently give it on the same day because I get confused, is there any action required?
Well, you might get confused, but our audience out there wouldn't do that, Jody, because they're medically accurate the whole time. But if it did properly happen, No, you don't have to bring them back. We don't have to repeat either of those vaccines. You just look after people, make sure they've got some Panadol at home, and check in on them in a few days' time. But you don't have to do anything.
Excellent. And Corinne's asking, is there any risk to fertility? I'm assuming with the COVID vaccine you mean there, Corinza?
Well, Corinza's a midwife, I know, so she's probably asking that. Yeah, so the recommendation at the moment is that we don't give the vaccine to pregnant women. If the pregnant woman is at high risk of getting COVID infection, then we would think that through. But at the moment we're not. But there's no recommendation to not give it to fertile young women who may become pregnant in the near future. And breastfeeding women, we're giving the vaccine to breastfeeding women, but not if you're actually pregnant at the time. So breastfeeding, it's okay to have the COVID vaccine. If you're not pregnant, but you may fall pregnant shortly, it's okay to have the COVID vaccine. So no impact on fertility. For Corinza.
And a question from Carolyn, which I really like. How does a practice register for Vax Tracker?
Oh, that is a good question. So that's actually got a complex answer. So where does she say where she works?
No.
No, so in general terms, the Vax Tracker program we're using at John Hunter right throughout New South Wales and in the Northern Territory, South Australia, the ACT and Queensland, and we're talking to Tasmania this afternoon, but it's Vax Tracker mainly is working with government institutions and hospitals. There's another program from WA called SmartVax. We all feed our data up to AusVac Safety, and SmartVax may be better depending what practice software you're using. So we've, who was that from? Carolyn?
Yep, Carolyn Keogh.
Oh, Carolyn Keogh. Okay, I'll contact you, Carolyn, and head you elsewhere. I know the Communicare software is really, really good, works really, really well in Aboriginal health services because it gives a lot more agency to Aboriginal health workers, but that's not a software that we're working with at the moment in that AusVac Safety program. So I'll talk to Caroline.
Okay.
And Patty, there's a question from Sarah. Is there anyone else who is advised not to have the vaccine?
Oh, that's a great question. So pregnant women, people under 18.
Anaphylaxis.
Yes, so if you have your first dose and you have anaphylaxis, you don't have your second dose.
Or history of anaphylaxis to any components of the vaccine.
Yep.
Or history of anaphylaxis to any previous vaccines, proceed with caution.
That's right. So if you have a history, if you carry an EpiPen and you have anaphylaxis, then you'd really want to talk to the GP at the AMS quite carefully before you have the vaccine. But there's no big categories of people because of specific medical conditions that we're excluding. In fact, it's quite the opposite. If you've got a chronic condition, then you're really at the front of the queue to be having the COVID vaccine. We're seeking you out to have it rather than excluding you.
And Patty, also from Sarah, is the gap between the COVID vaccine doses also 2 weeks?
Oh, that's a great question. So the AstraZeneca vaccine, which will be the vaccine we think will be in AMSs, it's a 12-week interval. 12-week interval between the 2 doses of AstraZeneca vaccine. The interval between an influenza vaccine and a COVID vaccine is 2 weeks.
So, Patrick, we had a question about where's the best space to get resources. And I guess there's a couple of pages that people could go to. Katrina Clark, the National Indigenous Immunisation Coordinator, is online at the moment. So she's posted a link to the National Centre for Immunisation Research and Surveillance FAQ pages, so that's in the questions. There's also the Federal Government Department of Health website. If you Google Immunise Australia, go to the vaccine program, click on resources. It's quite it's not an intuitive website. Click on resources. On the left-hand side, go to immunisations. There's posters, the pneumococcal brochure, the table that Patrick showed earlier, the meningococcal, the Aboriginal specific immunisation program schedule, the NIP. It's really good. And there's also New South Wales Health. If you Google New South Wales Health, On their website, on the left-hand side is what's new, and in the middle there's resources. So in particular, the Better Health Centre has resources, including a new anaphylaxis card that's recommended that you have in your clinic as well. I did have it on my name tag. It's a little laminated one with both sides. One side's giving you your adrenaline dosing, which is really easy with everyone being over 18 that's having the COVID vaccine, but it's useful because we're also giving childhood vaccines.
What's that dose for adults, Jodie?
Oh, that'd be 0.5 mil. Very similar to a vaccine that we have to give, I believe. Yep.
We've got a question about adverse events. What needs reporting as an adverse event?
Yeah, that's a great question. So if someone has what you consider a regular vaccine reaction, so a sore arm, a bit of a fever, feel a bit achy the next day, you don't have to report that. But anything else that happens, especially if it's something that, that you're surprised by, then it's really important that you report that. And you don't have to link whatever they're presenting with to the vaccine. You just report. If something happens after the vaccine, you just report that. So if someone comes with a new diagnosis after the vaccine, you would just report that. Because maybe it happens once in Taree and once in Adelaide and once in Darwin, and if we all report, we see what happens. And that improves the confidence in the vaccine safety. So minor aches and pains, a little bit of fever, a day off work, sore arm, you don't have to report those things. But you do have to look after people that have those things, so supply some paracetamol for them, a cold compress on their arm, whatever you think, symptomatic treatment. You guys are good at looking after community members, so do that. But anything else that happens, or if someone has any of those symptoms more extreme, then please report that. And don't be hesitant to report. The community have got to know that health workers and doctors and nurses are reporting on and all this data is looked at. There's no sense of that we're not informing people and keeping things to ourselves. It's a very transparent system. So it's a hassle reporting because it's a form, but it's really, really worthwhile in terms of community confidence.
And just building on that, Patrick, on the form, it's still business as usual. So on the National Adverse Events Reporting Form, page 7 tells you to send it to TGA. Just a reminder, in New South Wales, it's to go to your local public health unit. That way we also forward it to the TGA, but we'll contact your patient, review it within the team and work out recommendations regarding future doses. So if you do send it to the TGA, that's okay. Still send it to your public health unit so we can provide some feedback to you.
And the other things that are good to report is if someone has the first dose and you're uncertain whether they should be having the second dose, then please report that. That level of uncertainty tells you to report.
Yep. I think that's all our questions, Patrick.
Oh, really? I've got one here.
Okay.
Jodie was talking about little possums. Could we please define what she's talking about? She's talking about human babies, of course.
I am. I did ring one GP once and say, I just need to check if a little possum's been immunised at your surgery. And the lovely gentleman said, we don't immunise possums. I've just checked with the practice manager, and hung up on me. So apologies, I will call them babies and children.
Oh no, everyone knows now. Now we have to find our terms. Next Wednesday night for registered nurses that work at your AMS, we'll run a regular immunisation update, annual immunisation update with Todd, the sound guy, and Charles, the amazing organiser. Next Wednesday night, 6:30, for registered nurses and anyone who's interested. So you can do a regular immunisation update. So you do the online training for COVID, the Commonwealth online training. You do the regular immunisation update if you're an authorised immuniser, and then you're ready to give the COVID vaccine. And let's finish with Paula. Did you have any last words for the community, Paula, on having COVID vaccines?
No, I don't. Just support one another, I guess, and make our people feel safe. Get the right message out there to our people.
Fantastic. Thanks, Paula. See you, everyone. Oh, no. Charles. I forgot Charles. How could I forget Charles? Charles, don't go yet, please. Stay seated. Charles is going to come and finish up.
There's no worries at all, Patrick. No, I just wanted to close the session, everyone. So the event next Wednesday that Patrick mentioned, we will be advertising that from this afternoon. So registrations aren't open right now, but they will be from this afternoon. Just want to take the opportunity to thank everyone for presenting. So Patrick, Paula, Jody, and also Sharon in the background, thank you for your help. And just a reminder, if you could please complete the evaluation poll on the right-hand side of your screen before you log off. We really appreciate your feedback. So thanks again for joining us, and we hope you have a great afternoon.